Thank you, and I would like to extend a warm thanks for the organizers for giving us this opportunity to be here. It's always a pleasure to be back home and able to see the growth of nephrology that has occurred in India over the time. I left in 2000, and the last 15 years I've seen a huge change over the time. So this topic actually came up after discussions with Gaurav, Dr. Gaurav, the organizer on this program, when he mentioned that there are nephrologists here who would do angioplasties under ultrasound guidance. And that led to a couple of points back and forth, and that led to this talk. So let's start. So is ultrasound being used for angioplasty? And the answer is yes. And as far back as early 91, and this paper is from 1991, we had seen that, we had shown that you could use ultrasound safely to do, trying to get the point, to do angioplasties. And they were initially shown in animal models, and then a study from Germany showed for the first time that in about 38 patients with venous stenosis in dialysis access, the blood flow rates were down, and when they did ultrasound-guided angioplasties, they were able to reverse the stenosis and improve the access flows. And there were several advantages cited as to why using ultrasound may be better than what we have used conventionally is digital subtraction angiography for doing pretty much majority of the cases and is accepted as the gold standard. There is no radiation, which is, I think, the biggest benefit if I would want to use ultrasound for my patients. No IV iodine contrast. And iodine contrast have anaphylactic reactions, certainly have problems in patients who have chronic kidney disease. You have a risk of contrast nephropathy, so that is a potential benefit. And what Dr. Shenoy had alluded earlier and Dr. Malik had talked about is the flow dynamics of measuring the lesion and quantifying the lesion, not only in just the diameter, which you see under angiography, but perhaps dwelling a little more and looking at, is this really a significant stenosis? And that question cannot be answered by angiography alone. So that's a valid point under ultrasound-driven angioplasty. And because you're not using a C-arm, you're not using contrast, perhaps the cost is lower. But I would go back to a point about imaging is the key. So in this picture, if you just look at it from the outside, you see is two old men, old man and old woman. But if you dwell closely to their front, you could see two hidden structures, two individuals within the thing. Looking at angiography and finding the lesion is very important. Even when we do digital subtraction angiography, one view, one look at that lesion may not show, as shown here, if you had not taken a side view of this carotid artery, you would not have seen the stenosis and it would have been missed. So imaging is the key. And trying to identify the lesions and work on those lesions, moving wires, placing them across those stenosis. At times you have to use directional wires, directional catheters to navigate those stenosis. It's very important that you have good visualization of the end of your wire, the tract of the wire. If you use ultrasound to place wire, and as this ultrasound illustrates, that you could actually track the wire, and you can see the wire right in the middle of this vessel. You can confirm that this is a fistula by compressing on the fistula. It's a really soft fistula. We can try and look more longitudinal section of the fistula and identify that the wire is going in. But you could see the difference that even at best, it's very hard to track, and you really need a very dedicated radiation technologist to be able to do this real time while you're doing angioplasty. So that is a major challenge when you're using ultrasound guided wire placement. Again, an illustration, so if you have a wire in a peripheral shoulder, very easily seen. Compared this to what we just saw earlier, that with an ultrasound guided, it's very hard to see where the wire is going, especially in complicated lesions like this. This particular patient had a 100% occlusion of the graft vein and anastomosis, and trying to follow the wire, whether it's going beyond that stenosis, and you really have to have angiography with some side views to use directional catheters, maybe directional wires, to get across that lesion. So imaging is the key, and the better we can look at the lesion, the better we can analyze the flow. It's helpful in doing what is required to fix that stenosis. And that's the key. I think achieving success is an important part, and getting there is very useful if you use good technology and good imaging. The biggest series that has been reported on ultrasound-guided angioplasty was from New York. About 220 angioplasties in about 120 patients. So this is the biggest series that I've seen that showed very good technical success, and the technical success is pretty good all across the board. If you follow all the studies in about a decade's time, around 95-98% technical success. So just as good as angioplasty when you are able to perform those. And like I mentioned earlier, it gives you a lot of functional information about the flow. So if you have measured flow pre-angioplasty, you can measure flow post-angioplasty. You can come up with a delta or a percentage change in flow, which could be useful surrogate for defining the success or significance of a lesion. All the studies that I cited excluded patients if they had suspected or known central vein stenosis. You cannot follow your wires down in the central vessels. So directly, anytime you would suspect any central vein lesion, those patients are excluded from those studies. So they're out. Even if they've had a history of significant stenosis in the past, you really don't know if that's the lesion that's causing the problem or not. You need angiography to really study those lesions. This was a statement right off one of the papers. Inadequate fistula flow in the absence of limiting lesions on ultrasound. In other words, if you cannot find a discrete lesion on your ultrasound, you do not want to do an ultrasound-guided angioplasty. So it's really useful if you can identify a lesion on your physical exam, which the correlation between physical exam to find the lesion and ultrasound to find the lesion has been shown to be very good. So if you can find the lesion on your physical exam, perhaps you can go back and fix it ultrasound guided. But if you cannot, then you'll have to use angiography to look at the lesion. Most of these centers did these procedures outpatient office-based procedures and used local anesthetic to do these angioplasties, which is not really a limiting step. You could very easily do conscious sedation and do ultrasound-guided angioplasty. But just to point out that none of those papers that I pointed out, they excluded patients who wanted to be sedated prior to the procedure. So if we look at, and over the years we've found that the lesions are very widely distributed, with most common lesions, if it's a graft, is going to be at the vein graft anastomosis. But if it is a fistula, then you have the juxta-anastomotic area, the inflow part of the fistula, which is usually the point of stenosis. But invariably, and in about a quarter of the patients, it's either the outflow vein up in the shoulder, the cephalic arch, or up in the central vessels where there will be a stenosis. So that's a significant number of fistulas which will be left on the table if we are using ultrasound-guided angioplasty as the only method of taking care of patients with dialysis access issues. I'm not going to go into details about the success. We've kind of discussed that earlier. There is a probable benefit of using ultrasound post-angiographic angioplasty and pre-angioplasty to assess the lesion and better define which lesions really need that ballooning. Ballooning is invasive. It does increase the risk of Further, neointimal hyperplasia has been shown at several different centers in central veins and peripheral vessels. So using a predefined criteria at your center is a key. How about the technical failure? So the inability to cross the occluded anastomosis was the most important reason that was cited in all the ultrasound guided angioplasties as a cause for failure. And later during the day I have another talk on complete obstruction, which can be accessed in patients who have complete total obstruction of peripheral veins, of central veins, and before we say we cannot intervene and we need to call surgery, there could be other interventions that are available to us if you're using angiography and using techniques to cross those lesions. If there is a recoiling stenosis, that was also cited as a means for technical failure. And also remember, all the patients that were excluded are also clinical failures if you're using angioplasty with ultrasound alone. So the two main advantages that were cited were radiation and contrast. So let's look into that a little more. So if we compare radiation exposure across different segments, we see that the minors have a very high exposure. The radiology procedures overall in radiation suites have a much higher, very high exposures. Cardiologists get a very high exposures. And then there was data from Lifeline Center, which is one of the biggest providers for interventional nephrology care in United States. And they looked at all their interventional nephrologists and looked at the yearly exposure, yearly radiation exposure, and found that to be 375 millirems, much below the annual limits and much below what other societies and other clinicians are exposed to. So the radiation exposure is minimal, and very nicely shown in this paper from Dr. Dinesh, when you start performing interventional procedures and you were in the first 3 months of your practice or first month of your practice, your fluoroscopy times are much higher. And as you go along and you spend about a year and a half doing these procedures, your fluoroscopy time goes steadily down day by day, year by year, and your radiation exposures, both to the patient and yourself, will go down. And I've noticed that in our practice as well at the fellowship program, where we've trained several fellows. June or July, I'm probably getting a lot of exposure because my fellow is an extreme novice, and I do not give my driving fluoroscopy pedal to my fellow till I have made sure that they have read about radiation exposure. And then as you go along, the second half of their training, you can see them getting more competent and the radiation dose to the patient going down. So radiation can be minimized by using proper exposure techniques and also using proper protection equipment to prevent you from getting exposed. What about the contrast? And the patient allergies are extremely rare. The true allergy to contrast is extremely rare. And there are some surrogates we can use in a good history of prior exposure, iodine allergies, and what are the other comorbid risk factors? Patients who have asthma, patients who have other atopic dermatitis can have an increased risk of contrast allergies, but as I said, it's an extremely rare. And those patients who have had an anaphylactic shock in the past are the ones that I would absolutely not use contrast again. And I would be even worried about giving them a prophylactic steroid and getting them back into the interventional unit, because I'm really not sure if exposing them to that risk of contrast is worth taking that risk. And the second issue that frequently comes up is what about patients who are not on dialysis? Can I give them contrast? And at our center in Shreveport, the private radiologists do not want to do procedures on those patients and are always worried about the risk of contrast-induced nephropathy. And sometimes the procedures are required as pre-op mapping, especially in patients who've had central catheters in the past. The ultrasound guided mapping can give us excellent information about the peripheral vessels, but central vessels can sometimes be hard to visualize on that, and you need imaging to look at those better. The radiation safety has been addressed and looked at several different centers, and this particular study, they looked at patients who are getting contrast exposure, and they used ways to minimize the dose of the contrast, less than 20 ml of oxylan. And they found that the GFR change and the creatinine change were minimal, and only about 4% of the patients had an increase in creatinine on day 2 or day 7, and within 2 weeks, all of those increase in creatinines went away. In other words, if you limit the dose of contrast given to your patients with CKD, the risk of contrast nephropathy is minimal. At our centers, we've had hundreds of patients who've had CKD and have had procedures done. In my last 30 patients that I pulled up, the average GFR was about 18 at the time of contrast. The average contrast dose was 4.3 ml. So you could get away with doing these procedures with extremely small amounts of contrast and finding lesions and taking care of those lesions. And then you have another options for patients with severe anaphylactic reactions to contrast in the past. And this is something that we started using just recently at LSU. CO2 angiography traditionally was very cumbersome. The CO2 tanks were really huge. The setup was really a problem. And those were all noted disadvantages of doing CO2 angiograms. But this little system uses a canister which is very easily changed. A simple sterile tubing is attached to this canister. You pull up CO2 into a deploy syringe, and this is used to push CO2 into the patient for angiograms. No risk of any acute injury, no risk of anaphylaxis. So that gives you another way of finding the lesions in patients who do have significant lesions. And this is a patient with peripheral stenosis, central stenosis, and internal jugular vein stenosis, patient with peripheral venogram. So CO2 gives us just as good information as you would get with contrast, and could be another way of looking at it. Complications are always feared for, and we need to monitor our complications. The complications rate cited in patients who got ultrasound guided angioplasties were no different than what has traditionally been reported for regular conventional angioplasties. So there is no benefit there in terms of using. But then if you look at minor versus major complications, if you do have a major complication like a venous rupture after an angioplasty or an intimal tear after an angioplasty, it's much easily recognized with angiography versus ultrasound. And I would argue that the management and my comfort level in managing this complication would be a lot easier if I'm using angiography. So let's look at the case which I recently had. So this patient had a radiocephalic fistula. The patient was seen in our lab with an ultrasound. It shows the diameter of the fistula is about 5 millimeters. The depth is not big. They measured flow. It was about 400s. But the fistula is not maturing, and the patient has been seen twice at our interventional center. And if you look at this image here, you could see the fistula, but then you also see collaterals. You see collaterals, radial artery. And multiple collaterals were visualized, but we really didn't do anything about them. If you do an angiogram now, you see a series of collateral/accessory veins all over the place, and there is no one clear defined channel that you can follow for this patient. So you really need to have a good imaging to find out what is the problem in this patient's axis. So you need to get a catheter all the way up to the inflow radial artery, which is shown here, and now you could see a tight juxtaanastomotic stenosis, maybe some outflow stenosis, but you can't really tell because the flow is so slow into the fistula. There are these large collateral/accessories. There may be a minimal amount of radial artery stenosis that you could see. So you do balloon angioplasties, the inflow looks a lot better, flow comes in a lot better now, but you say the outflow is not really stenosed. It looked like it was stenosed because the flow was so low. Now that the flow comes in good, the veins are distended, and you can see two large accessories that are flowing out and taking away a lot of blood out, and also causing all these side veins or maybe causing difficulty identifying that main one channel. So another technique that we use sometimes is coiling of those accessory veins. So you need, again, directional catheters, directional wires to get into those veins, deploy a simple coil, occlude those vessels, and then you have a single channel outflow. And this fistula should be ready for use within the next few weeks after you're done with your procedure. Again, complicated patients with severe stenosis may need stenting. Imaging is a lot better. I showed you this picture earlier, rupture with a stent. The only study I could find which really compared subtraction angiography with ultrasonography was in patients with carotid ultrasounds. So they use digital subtraction angiography in all those patients and noted that as a gold standard and compared that with CT angiograms and duplex ultrasounds. And when you use those, the sensitivity was equal, so you could diagnose those lesions. But with an ultrasound, the specificity was low. With CT angiogram, the specificity was low. So the key is identifying those lesions accurately, and you may not miss, but you may overdiagnose some lesions which may truly not be there with an ultrasound. So imaging, again, remains the key in identifying the lesions really good. So to sum up, is angiography really the gold standard? I cannot say that one size fits all. You really have to look at your patient, look at your lesions, do a good physical exam, make sure that you do not leave the lesion unattended, because if you leave a catheter in a patient which should have been taken care of, and the catheter could come out if you can fix the lesion, and not doing so is doing harm to that patient. So for the right patient, maybe for the right lesion, and in the right hands, at the right center, ultrasound can be used as an effective tool to fix a discrete stenosis. But angiography does give you better imaging, can be the only option for central stenosis, and does perform better for more advanced and more complicated procedures. So having said all of this, I'm just going to introduce you to Louisiana. I know we have three of us from Louisiana, small state in southern part of the United States. Louisiana State University has its main campus in Baton Rouge. You must have heard this name recently with some shootings at Baton Rouge. And Louisiana Tigers and football is a passion, just like cricket is a passion here. And Louisiana Stadium, or the Tiger Stadium, is known for its parties and football. This stadium holds about 104,000 people, and on a Saturday night with the game on, it's the best place to be to enjoy with your friends. Our university has been very active in the field of nephrology and interventional nephrology. And over the years, we've trained several interventional nephrologists, and we have about three of us here from all trained at LSU, with over 30 interventional nephrologists trained over the years. And I welcome you all to come and visit us if you have an opportunity. So thank you again for giving me the opportunity to be here today. It was a pleasure, and I thoroughly enjoyed it.
Thank you, Bharat. Excellent talk. Your last slide on the subject sums it all: ultrasound versus fluoroscopy. I think probably the ball is very clear. There are certain indications where probably ultrasound might help. Maybe it can be a screening tool for many of us who have an access to ultrasound-based programs, but maybe fluoroscopy is an issue in some of the hospitals. So the topic is open for discussion, and any experiences if anyone wishes to share on this topic. Dr. D.Bhowmik, you want to share something?
Yes, at our institute, of course, we are doing the fluoroscopic guided interventions. But I'll just say one thing, that a small percentage of patients, especially when the GFR is around 15 or so, one has to be very careful with the contrast, because in that group sometimes you give contrast and then things can go wrong. So one has to be very careful. So I would just ask that about what percentage of your patients you are doing ultrasound guided still? Maybe around 20%?
We don't do any ultrasound.
Not at all?
No. So even in the CKD patients, which are about, I would say 5% or maybe less of those of our total angiographic procedures, we limit the amount of contrast exposure to less than 10 ml, and I think that's our rule. And we've not seen any case of contrast nephropathy if you limit the dose of contrast with that.
Fine. I think the small amount, there should not be a problem, but it has to be done appropriately.
Right.
Any more questions from the audience, please? Yes, Gulshan.
Yes, thank you for the talk. And there are 2 points which I want to know from you. First is, could you just elaborate how do you limit the dose of contrast to 4.6 ml for the studying the fistula circuit? And the second question was related to the, I do agree on certain indications of using ultrasound for the treatment of stenosis in a very small group of patients, because we have been taught that fistula is not just in the arm, it is just a circuit, and most of our patients, they come with the history of central catheters in the past. So I find very difficult to actually imagine using ultrasound just to do the stenosis angioplasties without knowing the central circulation.
Right. Just a show of hand, how many in the audience use ultrasound guided angioplasty? 1, 2, 3. How many of you use only ultrasound guided angioplasty for all your procedures? No one. So I think that's probably the message, that ultrasound can be used, I guess, for angioplasty, but it's not the only method that is out there, and it's, especially when there is a risk for central stenosis, we need to have better imaging. Going back to the limiting the contrast exposure, you really have to do your homework well in understanding the access as much as you can before you even cannulate. So a good physical exam, identifying the lesion on your physical exam, maybe using ultrasonography pre-op and knowing exactly where the lesion is. All you need is 1 cc of contrast to know where the lesion is. If you put your catheter through your brachial artery or your radial artery up the upstream, shoot 1 cc of contrast, you'll be able to get the imaging of the entire inflow and the body of the fistula. If you know where the lesion was on your exam, you can make sure that that's the focus area of study. You find the lesion, you could fix it, and then do 1 cc of post angioplasty contrast, and you'll be able to know that whether you fix the lesion or not. So technically, you could get away with just using 2 cc's for most of your cases. Now, if you also have to study central, you will need more contrast in those patients. So that's how we do dilute the contrast 1:1 or even 1:2 at times for these patients, and that helps in preventing the volume that you're pushing every time.
Yeah, just an extension of that question, if you do a venographic mapping of 2 hands before placement of fistula, how much contrast?
I would use 1 hand at a time. I would not do both. That's way to limit about half the contrast. I would use tourniquet, and we do use tourniquet. I use saline infusion into the arm before I even inject contrast, so all those vessels are well dilated. Try to use warm saline whenever that's available. Make sure that your tourniquet is high up in the shoulder. You give them 1 or 2 cc's of contrast. You don't need to do any fluoro DSAs. You'll be able to get most of your forearm veins and the upper arm veins with a tourniquet in place with just those first 2 cc's. Getting the central is more difficult in those patients, and sometimes I'll cannulate the basilic or the brachial vein, put in a catheter up those veins, and then do the central, because if you do it from the periphery in those CKD patients, you will need to use a lot more contrast to get better imaging. But if you have a catheter up in the axillary vein, you'd be able to get better imaging just with small amount of contrast.
So are you suggesting catheter
I think
use?
we have to conclude.
Yeah, are you suggesting catheter use for venous mapping up in
No,
the...
catheter is just a 5 French micropuncture catheter, you know, just to cannulate into the vein. Yeah.
Okay, thank you.
With that, we come to the end of the session. Thank you very much, Dr. Bharat Sachdeva, for an excellent talk.
Thank you, sir.